Beyond the stent and the script, cardiac rehabilitation as metabolic therapy, the molecular revolution in CAD, diabetes, CKD, and heart failure presenter, Dr. Ashutosh Mishra target, cardiologists, interventionalists, intensivists, the talk colleagues. Let me start with a provocation. What if I told you that the most powerful metabolic drug we have isn't in our pharmacy, it's in our rehabilitation gym? We've become masters of the acute intervention. Stents in 90 minutes. Door to balloon times that would make our predecessors weep with joy. But here's the uncomfortable truth: we are winning battles and losing the war. Because atherosclerosis, diabetes, heart failure, these aren't plumbing problems. They are metabolic catastrophes playing out at the mitochondrial level. So today I'm going to take you on a journey from the catheter table to the cellular powerhouse and show you why cardiac rehabilitation isn't just exercise therapy, it's precision metabolic medicine backed by molecular mechanisms that rival any drug in our arsenal. The mitochondrial crisis. Let's start where the disease starts, the mitochondrion. In our patients with CAD, diabetes, CKD, and heart failure, the cardiac mitochondrion is sick. And I mean that literally: decreased oxidative capacity, impaired electron transport, excessive ROS production, pathological fission creating fragmented, dysfunctional organelles. The heart is energy starved despite having plenty of substrate. Here's the data. Lim and colleagues published a systematic review and meta-analysis in International Journal of Molecular Sciences in 2022 looking at mitochondrial function in CVD patients. They found that exercise training improved mitochondrial oxidative capacity with a standardized mean difference of 4.78, that's 95%, CI 2.99 to 6.57, P less than 0.01. For context, an SMD above 0.8 is considered large. We are talking about a nearly 5 standard deviation improvement in mitochondrial oxidative capacity. When was the last time you saw a drug do that? The AMPK PGC1 axis, the master switch. So how does exercise accomplish this mitochondrial resurrection? It all starts with AMPK, AMP activated protein kinase, your cell's fuel gauge. When you exercise, ATP gets consumed, AMP rises. AMPK senses this energy deficit and says we need more mitochondria and we need better mitochondria. It activates PGC1 and peroxisome proliferator activated receptor gamma coactivator 1 alpha, the master regulator of mitochondrial biogenesis. Shah and colleagues just published in International Journal of Molecular Sciences in December 2024. Literally last month, a systematic review of exercise training on cardiac mitochondrial function, specifically in diabetic hearts. They found that exercise consistently upregulated AMPK and PGC1-IU in cardiac tissue across multiple animal and translational studies. But it doesn't stop there. Exercise also activated ACTI, increased irisin, and elevated SIRT3, the mitochondrial sirtuin that regulates oxidative metabolism. And here's what that translates to functionally: increased complex ABA and complex 2 activity, the electron transport chain enzymes that actually make ATP. In diabetic rat hearts subjected to endurance training, lactate dehydrogenase activity increased. Complex ADA activities went up and ATP production was restored. We're literally rebuilding the cardiac powerhouse enzyme by enzyme. The SIRT1 NAD redox revolution. Now let's talk about something even more elegant, the N8+ redox system. Corby and colleagues published a beautiful full study in oxidative medicine and cellular longevity in 2019 on HFpFPF patients' heart failure with preserved ejection fraction, where we have almost nothing pharmacologically. They took these patients through just 4 weeks of supervised cardiac rehabilitation, not years, just 1 month, and measured molecular outcomes. Here's what happened. SIRT1 enzymatic activity increased significantly, NAD+ levels, ROD+, NADH ratio improved. This is your cellular redox state, the balance between oxidized and reduced coenzymes, high hydroxybutyrate levels, increased ketone bodies, alternative cardiac fuel, total antioxidant capacity went up, oxidized LDL went down. Let me translate. In 1 month, we shifted these failing hearts from a pro-oxidant, metabolically inflexible state to a metabolically resilient state capable of using multiple fuel sources, glucose, lactate, ketones with improved redox balance. SIRT1, by the way, is NAD+ dependent. It's a deacetylase that regulates PGC1-IU mitochondrial biogenesis, autophagy, and inflammation. It's basically the longevity molecule. And we turned it on with exercise, mitochondrial quality control, dynamics, fission, fusion. But making new mitochondria isn't enough if the old, damaged ones stick around. This is where mitochondrial quality control comes in. In diabetic hearts, you see excessive mitochondrial fission. The mitochondrial network fragments into tiny dysfunctional pieces driven by proteins like DRP1 and mitochondrial fission factor. This is pathological. The systematic review by Shah showed that exercise training decreased DRP1 expression and reduced pathological fission in diabetic cardiac models. The mitochondrial network shifted toward healthier morphology, more elongated, interconnected mitochondria with better membrane potential. Now, the literature is still emerging on specific mitophagy markers like PINK1 and Parkin in human cardiac rehab studies. We don't have consistent quantitative data yet. But what we do see is the functional outcome: improved mitochondrial membrane potential, lower OS production, higher ATP output. The net effect is clear. Exercise improves mitochondrial quality control, removing damaged organelles and replacing them with high-performing ones. The inflammatory cascade, cytokines and adhesion molecules. Let's zoom out from the mitochondrion to the systemic milieu. Chronic inflammation is the accelerant that drives atherosclerosis, diabetic complications, and heart failure progression. Here's a randomized controlled trial. Cardiac rehabilitation in women with coronary heart disease, measuring inflammatory markers before and after. Published data showed HSCRP decreased high-sensitivity C-reactive protein. Your acute phase reactant IL-6 decreased interleukin-6, a pro-inflammatory cytokine TNF decreased tumor necrosis factor alpha. Another inflammatory driver, ICAM1, decreased intercellular adhesion molecule 1 involved in leukocyte adhesion to endothelium. We are not just reducing symptoms, we are dampening the inflammatory cascade at the molecular level. And this matters because these cytokines drive endothelial dysfunction, insulin resistance, and myocardial remodeling. By lowering them, we are attacking the root pathophysiology, metabolic syndrome. The clinical translation now let's see how these molecular mechanisms translate to clinical metabolic outcomes. A meta-analysis of cardiac rehabilitation programs, 15 studies, nearly 20,000 patients, published in 2024, showed that CR reduced metabolic syndrome prevalence by 25%. But look at the individual components. HDL cholesterol plus 2.13 milligrams, DL triglycerides 27.45 milligrams, DL fasting blood sugar 6.42 milligrams, DL waist circumference 2.25 centimeters, systolic BP 6.20 millimeters of mercury, diastolic BP 2.53 millimeters of mercury. Every single component improved. But here's where it gets really exciting. An enhanced cardiac rehabilitation program published in Current Problems in Cardiology in 2023 combined exercise with intensive nutrition, Mediterranean diet principles, reduced ultra-processed foods, time-restricted eating. At 6 months, weight loss, 8.0 kilograms waist reduction, 9.2 centimeters prediabetes remission, 50% metabolic syndrome remission, 70%, let me repeat that, 70% of patients achieved metabolic syndrome remission, not improvement, remission. Show me a drug that does that. The insulin signaling pathway. From receptor to GLUT4, let's get granular on insulin resistance because this is the linchpin in diabetes and metabolic syndrome. Exercise activates the insulin signaling cascade. When insulin binds its receptor, it triggers a phosphorylation cascade through IRS1 and PI3K to act. Studies in diabetic cardiac models showed that exercise training increased ACT phosphorylation and activity in cardiac tissue. Activated ACT does multiple things. It promotes GLUT4 translocation to the cell membrane. GLUT4 is the glucose transporter. More GLUT4 at the surface means more glucose uptake. It activates glycogen synthase, storing glucose as glycogen. It inhibits GSK3, preventing glycogen breakdown. It promotes eNOS activation, endothelial nitric oxide synthase, improving vasodilation. Now, I'll be honest with you. We don't yet have consistent human cardiac rep data directly measuring GLUT4 translocation in cardiac tissue that requires invasive biopsies. But we have the surrogate markers and we have the clinical outcomes. The pathway is being engaged. The biology is happening. substrate flexibility, from glucose to lactate to ketones. One of the most elegant adaptations of cardiac rehabilitation is metabolic flexibility, the heart's ability to switch between fuel sources. The failing heart, the diabetic heart, they're metabolically rigid. They over-rely on fatty acid oxidation, which is oxygen inefficient and generates more ROS per ATP molecule. Or they can't properly oxidize glucose because of insulin resistance and mitochondrial dysfunction. Exercise training restores substrate flexibility. The Corby study showed increased hydroxybutyrate, a ketone body, in HFpF patients after rehab. Ketones are a highly efficient cardiac fuel, producing more ATP per oxygen molecule consumed than fatty acids. Exercise also improves lactate metabolism. The heart learns to use lactate as fuel. Lactate isn't waste, it's a redox currency shuttling between tissues. The trained heart preferentially oxidizes lactate during exercise, sparing glucose and improving overall metabolic efficiency. And in diabetic models, exercise increased lactate dehydrogenase activity, the enzyme that interconverts lactate and pyruvate, alongside improved electron transport chain function. The heart becomes a metabolic omnivore, capable of thriving on whatever substrate is available. Oxidative stress and the redox balance. Let's talk about reactive oxygen species ROS. A little bit is signaling. Too much is damage. In CVD, diabetes and heart failure, you have oxidative stress, excessive ROS production from dysfunctional mitochondria, NADH oxidase and uncoupled eNOS. This oxidizes lipids, damages proteins and mutates mitochondrial DNA. Exercise training counterintuitively initially increases ROS during the workout. That's the stimulus. But chronically it upregulates antioxidant defenses. Superoxide dismutase converts superoxide to hydrogen peroxide catalase, breaks down hydrogen peroxide to water. Glutathione peroxidase reduces lipid peroxides thioredoxin system, maintains protein redox state. The Corby study showed increased total antioxidant capacity after just 4 weeks of rehab. Oxidized LDL decreased. The NAD to NADH ratio improved, shifting the cellular environment from reduced to more oxidized. In diabetic heart studies, exercise reduced ROS production and improved mitochondrial membrane potential, a direct indicator of electron transport chain efficiency. We are restoring redox homeostasis at the cellular level. The endothelial renaissance, eNOS and nitric oxide. The endothelium is the metabolic interface between blood and tissue. In CVD, its dysfunctional, impaired vasodilation, increased permeability, prothrombotic, pro-inflammatory. Exercise rehabilitates the endothelium. The mechanism centers on eNOS, endothelial nitric oxide synthase, the enzyme that produces nitric oxide from L-arginine. Shear stress from increased blood flow during exercise activates eNOSic through multiple pathways. ACT phosphorylates eNOS at SER 1177. Increasing activity, AMPK phosphorylates eNOS, also activating it. Increased calcium flux activates calmodulin, which binds and activates eNOS monoamines. Vasodilation, improved blood flow, reduced afterload, antiplatelet effects, reduced thrombosis risk, anti-inflammatory signaling, reduced leukocyte adhesion, mitochondrial biogenesis. No stimulates PGC1. The clinical literature consistently reports improved endothelial function after cardiac rehab measured by flow-mediated dilation or reactive hyperemia. We saw ICAM1 decrease, that's reduced adhesion molecule expression on endothelium. We are rejuvenating the vascular interface. The chronic kidney disease challenge. Now what about our CKE patients? We often hesitate to push them hard because of concerns about volume status, electrolytes, and progression. But here's the evidence. A lifestyle intervention study in obese CKD patients, supervised aerobic training plus caloric restriction, produced significant weight loss, increased VO max, improved insulin sensitivity, favorable adipoking profile, increased adiponectin, decreased leptin. Importantly, these metabolic benefits occurred independent of short-term GFR changes. We are not necessarily reversing kidney disease in 12 weeks, but we are improving systemic metabolic health, which has long-term renal protective effects through reduced inflammation, oxidative stress, and endothelial dysfunction. The key is appropriate tailoring, moderate intensity, supervised progression, monitoring volume status and electrolytes. But the biology works. The pathways are engaged. putting it all together, the molecular cascade. Let me synthesize this into one integrated molecular cascade. Exercise stimulus AMPK activation plus calcium signaling, mechanical stress PGC1 upregulation plus SIRT1 activation, mitochondrial biogenesis, improved oxidative phosphorylation, increased AP production plus decreased OS, better contractile function plus reduced oxidative stress, improved insulin signaling, GLUT4 translocation plus glucose uptake, glycemic control, reduced insulin resistance, ENOS activation, nitric oxide production, vasodilation plus anti-inflammatory effects, improved endothelial function, reduced inflammatory cytokines, decreased systemic inflammation, improved lipid metabolism, reduced atherosclerotic progression, clinical outcomes. MET prevalence, cardiovascular events, mortality. This is a self-reinforcing positive metabolic cascade. The clinical impact, mortality and morbidity. Let's bring this back to what matters. Does this saves? Yes, unequivocally. Meta-analyses of cardiac rehabilitation show 20 to 30% reduction in all mortality, 26% reduction in cardiovascular mortality, 25% reduction in hospital readmissions, improved quality of life across all domains. And now we understand why it's not just exercise is good for you. It's mitochondrial biogenesis and improved oxidative capacity, restored NAD+, NADH, redox balance, dampened inflammatory cascade, improved insulin signaling and glucose metabolism, enhanced endothelial function and vasodilation, metabolic syndrome remission in 70% with enhanced programs. We are targeting the molecular pathophysiology of cardiovascular metabolic disease. A call to action. Beyond the stent and the script, colleagues, here's my challenge to you. The next time you place a stent, ask yourself, have I restored mitochondrial function? Have I activated AMPK and PGC1? Have I improved the NAD plus ND ratio? Have I dampened IL-6 and TNF? The answer is no. The stent opened the artery. That's necessary, but it's not sufficient. The next time you write a prescription for a statin, an AC inhibitor, a beta blocker, again necessary, evidence-based, life-saving, ask yourself, have I addressed the metabolic catastrophe at the cellular level? We need to think of cardiac rehabilitation as a drug, a metabolic drug with pleiotropic effects. Target AMPK, PGC1 and SIRT1, ENOS, insulin receptor pathway mechanism. Mitochondrial biogenesis, improved oxidative phosphorylation, reduced inflammation, enhanced insulin sensitivity, endothelial rejuvenation dose, supervised exercise 3-week, moderate to vigorous intensity combined with medical nutrition therapy, effect size SMD 4.78 for mitochondrial function, 70% METs remission with enhanced programs, 26% reduction in CV mortality, side effects, improved mood, better sleep, increased functional capacity, enhanced quality of life, cost, a fraction of our pharmacologic and procedural costs. We need to prescribe it as rigorously as we prescribe aspirin and statins. Conclusion. The molecular revolution, colleagues, we stand at the intersection of molecular biology and clinical cardiology. The last 2 decades have revealed that exercise isn't just good for the heart in some vague, hand-wavy sense. Exercise is precision metabolic medicine. It activates AMPA and PGC1. It increases SIRT1 and NAD+. It builds mitochondria with SMD effect sizes of 4.78. It reduces IL-6, TN and SC. It activates ACT and promotes GLUT4 translocation. It stimulates ENOS and produces nitric oxide. It shifts substrate metabolism toward flexibility and efficiency. And clinically, it achieves 70% metabolic syndrome remission, 50% prediabetes remission, and 26% reduction in cardiovascular mortality. That's not adjunctive therapy, that's foundational therapy. So yes, place the stent, write the script app, but then send the patient to cardiac rehab and say, this is where we fix your metabolism. This is where we rebuild your mitochondria. This is where we turn on your longevity pathways. This is where we give you your life back. Beyond the stent and the script, there's molecular metabolic transformation. Thank you.